you, Dr. Atik. It's my pleasure to introduce Dr. Mailliard. We met, I think, on the first week of July in 2007 as a liver fellow at a very busy 4th of July weekend with lots of food boluses and excitement. So Dr. Mailliard and I have known each other a long time, and it's my pleasure to introduce him as he's the Fred Paustian Professor in Internal Medicine and the Chief of the Division of Gastroenterology and Hepatology in Omaha, Nebraska. And his interest has been in hepatitis C, screen, treat, and cure. I would add that as a fellow, we were more like screen, wait, and hope was more like when I was there, as our therapies were quite limited and have expanded greatly in the last few years. So, Dr. Mailliard.
Well, we have a lot to talk about today because, in 30, 40 minutes, I'd like to review what's going on with hepatitis C. And as Lee was just saying, we used to have to get our cheerleader outfits on and our pom-poms and plead with patients to take interferon-based therapy, and we really come a long way from there. So now we can actually cure patients, and all the nephrologists and the other services around us are really sad because we're, curing patients right and left. So we're going to talk about, curing and eradicating hepatitis C infections. We're going to talk about the hope of eliminating hepatitis C from this planet. And by doing that, we're going to say what everybody should be thinking about is screening and finding hepatitis C, treating it, and then curing it. So, you guys don't think about hepatitis C maybe every day, but you remember the hepatitis viruses were given letter designations A, B, C, D, E, because, the clinical sequelae, the natural history was known far before any molecular diagnosis existed. Hepatitis was described in very remote times, ravaging armies and attacking Greece and Rome and whatever. And so there's all sorts of descriptions of jaundice wiping out people, but their molecular identification really lagged behind. And hepatitis C is just like these others. That non-A, non-B hepatitis was what it was called for years, and the natural history was somewhat understood, but in 1989, which to me is recent past, the hepatitis C virus was finally identified. Now, the workers who did this at Chiron and San Francisco should have got the Nobel Prize because, as you'll see, the identification of the virus, well, it ridded the blood supply. So 1992, the U.S. and certainly thereafter the global blood supply was free of hep C. Before then, particularly in the 70s, if you had 6 units of blood after a coronary artery bypass graft in Seattle or Baltimore, you got hep C every time. So having the blood supply safe is a remarkable thing. And then shortly thereafter, the FDA approved interferon. We won't talk much about interferon today, but needless to say, although right away it was shown that it could cure hepatitis C, it was probably one of the harsher therapies that non-oncologists would ever use. In 1998, the CDC says screen everybody at risk for blood-borne infections, okay? And that really didn't do much. In 2007, United States deaths from hepatitis C exceeded those from HIV. And then in 2013, finally, screening based upon age, baby boomers born between 1945 and 65, and, of course, blood-borne risk should be the basics. And so that we would expect internists, family physicians, generalists, everyone asking about hepatitis C screening. But we have a long way to go. Only about 15% of eligible adults have been screened in the United States. In 2014, as I'll spend most of the talk today, direct-acting antivirals became available that quickly showed cure rates of around 95%. And we'll talk about that a little bit today and see how that's changed my life and most people's lives who dealt with hepatitis C fairly frequently. So now the first news is the deaths from hepatitis B and C globally exceed malaria, tuberculosis, syphilis, et cetera, et cetera. So the hepatitis viruses are really the scourge of the planet, and need and are being dealt with. And fortunately, hepatitis B is completely suppressible fairly easily. Now, curable is a whole nother problem. You know, hepatitis B is a DNA virus, and therefore it is integrated into your genome if it ever gets in your blood, which means it's there forever. So hepatitis B patients, in theory, if they get immunosuppressed strong enough, it will recur and reactivate. And you know, nowadays, you know, monoclonals that the oncologists use are amazingly immunosuppressing. And so hepatitis B lurking in all sorts of people, although totally suppressed, dormant, whatever, it can recur. Hepatitis C is an RNA virus, and once gone, gone forever, will not reactivate unless you get infected again. Different from B, there is no immunity for C. Okay, so globally, about 400 million people have Hep B or C or both, and most of these are not living in United States. You can see in the little pie diagrams, the light blue is B and the dark blue is C, and you see in the United States and North America, C outweighs B by quite a bit, but if you move east, you see that's a totally different story. But this is big news for the movement from malaria, tuberculosis into these hepatitis B and C, and a lot of attention is being paid to this. So, reminder, of course, anyone who's at risk for a blood-borne infection can get hepatitis C. And, you know, for us, mostly that's through a percutaneous exposure. Now, it's very important to say that's not just the needles, but the syringes that are attached. Again and again, we see evidence of populations, local, small, big, large, whatever, believing that needles alone, you know, and transfer and clean needles is all you need. But the syringes are a source of infection easily. Now, whether this is through illegal or illicit use of percutaneous agents or nosocomial or occupational, it really doesn't matter. But I show nosocomial right away. You know, the CDC would say that about every week there's an outbreak of nosocomial hospital or clinic-associated hepatitis C in the United States. So just today I see that 2,600 people are going to be screened for hepatitis C in one clinic. 2,600 people. So breaches in infection control remain a huge problem. A couple of years ago, there was a nursing home outbreak in, I think, Fargo. And in Omaha, I had the very interesting experience of seeing 100 people who got hepatitis C during a 6-month period in a cancer clinic. So remember that this does happen, and particularly where infection control is not top-notch. Many of the patients who have Hep C do not know they have it, and their age being 65 are entering clinics where infection control is spotty. There's going to be outbreaks of Hep C. If you had a transfusion, a blood transfusion, a tissue, organ, whatever, pre-1992, you're certainly at risk for Hep C. And then HIV, particularly men who have sex with men, are at risk for hepatitis C. And I remind you that there's no immunity. And so that people who have Hep C and are cured by therapy can reacquire it quite easily. So in the United States, the bulk of the people infected lie within a certain age range, as I already mentioned, with about 85% lying between 1945 being birthed and 1965. And so, you know, why that is has to do with, you know, bad decisions with needles, you know, in the 60s and early 70s. And, you know, Gilead has used this very powerfully in their commercials if you watch CNN. And these commercials are highly effective at reaching this population. Just, you know, if you think they look silly, you know, I don't live on the beach and walk on the beach and gaze out the ocean, but there are lots of people who identify with the people there. Now, so antibody screening is very effective, okay, and very specific. So over the last 20 years, the antibody ELISA has become better and better and better. So if you have a history of needle stick risk and your antibody is positive, it's going to be truly positive. But all laboratories that are doing this test should immediately confirm all antibody positives by checking the hepatitis C viral RNA and showing that it truly is a viremic individual. Because I'll show you in a little bit about what the percentages of that are, but again, if your laboratory is not doing that, they should be urged to automatically do that and not being delaying any sort of confirmation by measurement of virus. So the CDC, the United States Public Services Task Force, say that all adults born during 45 and 65 should have a one-time test for Hep C without any other discussion of any nature. Did you have beads on in 40 and 65? It doesn't really matter, okay? So, it's very, very simple.
Mark, is that the population you reference when you say only 15% have been checked so far?
Yes. Okay, yes, absolutely. So persons with the antibody and RNA positive then should always receive immediately alcohol screening. Alcohol abuse screening, are you comfortable talking with your patients about alcohol? Well, since we're all comfortable with alcohol, does that mean you're comfortable discussing it with people? It's another problem. They say that about 35% of Americans don't drink at all, but since I don't know anyone like that, I think that it's smaller than that. And South Dakota, Nebraska, Wisconsin, and Minnesota are the kings of binge drinking. This to be so. So it's I think you can't go to a bar mitzvah, you can't go to confirmation without alcohol. You can't go to a high school seniors party. The white cake, that special white cake with the strawberries and the sandwiches that are cut, and then there's the keg for the parents. What? I think it's really, really very fascinating to me that this goes on and the kids are hoping that they can ditch the party as soon as possible. So that's just my view of this. So alcohol abuse is very, very common, and it wouldn't be surprised that these individuals who have hepatitis C are also using alcohol regularly. Alcohol and hepatitis C is fire and gasoline. So they should receive some intervention, and then they should be treated, period. So the indication for hepatitis C therapy is the presence of hepatitis C, period. Okay? Indication for colonoscopy being a colon. Okay, so we're going to talk about hepatitis C. Remember that you're always asking yourself, do you understand the natural history of illness? Because how can you decide what to do if you do not know what happens if you don't do anything? Okay? So, we're going to talk about the natural history for a few minutes. And remember, so everybody has acquired the infection through some site. Most of them do not remember when they got it. And it's extremely rare for them to even identify a clinical illness that, oh yes, that's when I got it. So there is no reason. I say, the patients want to talk about this, but it's water under the bridge. It happened during their most intense exposure to needles, but that can be dicey with a lot of people. We don't dwell on it. Most of the people in this population are clean and sober. Gradually, their journey is toward clean and sober, okay? So again, they've had an exposure. You're not going to identify it. Now, about 85% acquired an infection and 15% did not. Okay, so that's why you have to confirm that the antibody is truly representative of viremia. So because 15% at least will lose it on their own. We don't know how. We know the immunity to hepatitis C is really weird. There is no vaccine, and there might not be a vaccine in our lifetime. Do you know that's really, really strange, okay? Because actually, you put them in a test tube together, and there's a kind of a vigorous immune response. But again, the patients don't remember fever, chills, dark urine, arthralgias, nausea. They don't have that background. So it's a very interesting phenomena, and immunity and virus loss, again, is poorly understood. But most patients are developing a chronic hepatitis. So now you remember, hepatitis means liver inflammation. And you know, the ALT and the AST are really the only markers for that. And the ALT and AST, since they were made based upon white men, okay, so and the average white man weighs about 25 pounds more than he should, that the ALT and ASTs are too high. So the fact that they're 45 and 50 is probably too high for more. So most people's ALT and AST should be 17, okay? 19. So if you're one of those people, score. But you know, the whole thing is that your ability to diagnose hepatitis only based upon ALT and AST is missing a sizable portion of people, okay? So just be paranoid about that. Now, over decades of chronic liver irritation, cirrhosis, a bad term, scarring will develop. Scarring, right? This scar, just like if you have chronic irritation of your joints, you get scarring, right? The same thing is happening to your liver. It happens very quietly. About 15 to 20% of all autopsy studies of adults identifies cirrhosis in the liver. None of these people knew they have it. They didn't have ascites, edema, erythema. They didn't have it, okay? And so it's very, very common for so many reasons. Alcohol, hep C, fatty liver, whatever. It's the natural history of humans being human, okay? So, but when you talk about this to internists, family physicians, patients, their family, they're mortified by that term. So get over it. It's very common, okay? And I only say this because I tell my residents yesterday, if you hear Rawls and there's an S3 and there's peripheral edema and they have trouble sleeping at night because they get short of breath, does that scare you? Does that mean you won't tell people what they have? But this thing about transaminitis, what the heck is that? If someone has an elevated liver enzyme, they have hepatitis, and tell them they do. And don't be afraid and call it some sort of nonsense and beat around the bush. Your job is to identify the hepatitis, what the cause is, and do something about it. Because if you don't, you have portal hypertension. Not really liver failure. Liver failure is a rarity, but portal hypertension is very, very common. And we all know what happens to people who have portal hypertension, and it can be horrible. But as I tell my children, you know, you're driving down the street and you see somebody come out of the bar and they have ascites and jaundice, and my 12-year-old says, look, there's somebody with cirrhosis. It takes no brains to identify at ascites, jaundice, that they have cirrhosis. Our job is to identify it long before that, right? And then you have hepatocellular carcinoma. Okay, now, if it wasn't for our exposure to the sun, hepatocellular carcinoma would be by far the most common cancer in the world. Melanoma is number one. Liver cancer is probably two, but the people who get liver cancer, they're not exactly popular, okay? So, and they're all over the world, and so this is vastly underrated. So if you look, our goal is to treat these people early and prevent all this sequelae, and I try to present it as if Hep C is a big deal, not a nuisance, as many clinicians will try to say it's not a big deal, what's the worry? And I don't have time to go into that. Okay, so you get cirrhosis at a certain rate, that's scarring, which could be really a lot of badness. And So that if you acquire the infection as a young person, okay, the acquisition of cirrhosis takes decades. But the worst thing that could happen is you acquire hepatitis C after age 50, because then you have a very rapid progression to scar. Okay, just something to know. So when you see 17 years old and they're now 40 and they don't have scar, it's like that. And I don't know why. Probably has something to do with immunity, but you don't know that, okay? So both men and women acquire cirrhosis very slowly, with men actually having a much higher rate of acquiring it than the women. Now, we talked about hepatocellular carcinoma and this big spike in liver cancer that's going to be globally. So if you take care of urban males, okay, you're going to see liver cancer regularly. And so, especially in gastroenterology, we see hepatocellular carcinoma about once or twice a month. New diagnosis, okay? And if you see a lot of urban people who are needy, you're going to see liver cancer fairly regularly. So the goals of therapy is to eradicate and cure. And again, cure, what a great word. Treating this is going to be like treating oral candidiasis. It is easy, okay? So the definition of sustained virologic response is undetectable hepatitis C 12 weeks after therapy. That's how you know someone is cured. You never have to draw a hepatitis C blood test again if they have no virus 12 weeks after therapy. It's over, they're cured. Now, eradicating virus improves liver injury histology and ends, slows, or halts the progression of cirrhosis and liver cancer, but it doesn't guarantee that their alcohol abuse, the other things that are happening, their fatty liver, and that their molecular signal for liver cancer will go away. We're seeing lots of liver cancer still in people who have been cured. Although the rate falls, it's not zero. So this SVR, this cure, is durable, lifelong in every study, okay? So 99.7% stay HCV negative after cure. The other 3% resumed that risky behavior, and that should not be any surprise. So if you're in San Francisco or Detroit or New York or Miami, you see reacquisition of hepatitis C regularly in your patients, okay? We talked about what it does to people. It decreases the mortality. It increases the quality of life and well-being. But the patients usually don't come in and say, now I feel like doing jumping jacks. It's not like that. But many of them feel dramatically better. Getting placebo effect of being elated about after worrying about this every day and then not have to worry, I can't tell how much is what. So just like everything else, we've gone from not knowing anything about this to knowing a lot about this virus. And so what's happened is, since we finally knew a lot about it, we figured out how to treat it. Now, us mortals didn't figure out how to treat it, all right? So the molecular scientists at Emory in the Atlanta VA figured out how to treat it using agents that had been tried on HIV and failed. It's really straightforward. Now, he's worth several $1 billion, and the VA never got a dime, but that's America, right? So, but I just kind of show that how this kind of goes and kind of how this moves forward slowly. Now, sometimes this is when people's eyes start glazing over. There's 6 genotypes, okay? And it used to be that there was a lot of anxiety about the genotype because the treatment was very different for the different genotypes of hepatitis C. But we're into pan-genotypic era, and so it's not so important. But the insurers and the pharmaceutical companies require genotypes to be done on the patient's application for therapy. So we're going to talk about that in a little bit. You still have to do it. You see these little families, 1, 2, 3, 4, 5, 6, right? But 75% of people have genotype 1. The natural history of the infection for the different genotypes is probably identical. But genotype 3 patients, it's probably a little worse. So that's just a little thing that's finally, we suspected this years ago because around Omaha there's a little cadre of genotype 3 patients, and I don't know why. We suspected they did worse than everybody else, and now it seems like we're right. So over the years, I finished my GI fellowship in the 80s, and I had an office next to the world's expert in hepatitis C, and that led to my interest in this and somewhat my expertise. And so we gave interferon injections 3 times a week to patients mortified about what would happen to them. And, we maybe got a 15% cure rate, okay? The patients had hundreds of side effects. And then we added ribavirin, and they had hundreds more side effects, but the cure rate doubled. And we were kind of at a big plateau because the therapy was frankly very harsh. And you were dealing with patients who felt pretty well, giving themselves sub-Q injections when they were mortified about their past history of using needles, and giving ribavirin, which, I don't know if you've ever given ribavirin. It's a very bad medicine. Avidly taken up by red blood cells and kills red blood cells fairly easy. So you get anemic, you feel exhausted, and the interferon is driving you. It has lots of central nervous side effects. It's driving you crazy. So finally in 2014, the direct-acting antivirals became common and changed the whole landscape of therapy. Because when we were treating in the past, we would have these sort of pill burdensome response guided therapy. That reminds me on the right there, the top would say you're hyponatremic, and then you go through all the steps, urine tests and things, and then finally at the bottom it says call the nephrologist. So this was very similar, and so I was the only one doing this. Everybody else thought I was crazy, and so I had all these patients. So then when the cure came out, I had hundreds of patients that call warehoused, and I was able to treat. We've treated 850 people over the last 3 years with a 94% cure rate. And why is that such a big deal? Because every prescription in the beginning produced about $45,000 in profit. So it was by far the most profitable medication, and Nebraska Medicine made $25 million off my clinic. So it cost about $300 to bring the patient in, and they made $25 million. So I became a very, very happy person. I didn't get a dime, but they're working. The sculpture of the gold statue is working out very nicely. So, and what we saw is that cure changed the chances of portal hypertension complications and changed the occurrence of liver cancer. Okay? So dramatic differences with cure. And then the VA did this study. Around 10,000 vets with hepatitis C got treated, got cured, and then they said what happens to them. So whether it was congestive heart failure, COPD, or diabetes, they all died less from those problems as well. So all-cause mortality, not just liver. So hopefully I'm convincing you that hepatitis C therapy can be thought to be cost-effective because of the dramatic effect on the patient's well-being and the natural history. So, but I warned you that patients with cirrhosis who get cured still have a risk of hepatocellular carcinoma. The older the patients, the presence of diabetes makes this worse, but it doesn't go away. So I tell my patients they have about a 1 out of 75 chance of getting liver cancer before therapy, and about a 1 out of 500 chance of getting liver cancer afterwards. And you're thinking, that's not so bad. But your chances of getting liver cancer is about 1 in 100,000. So No comparison, right? Okay, so the ideal therapeutic regimen would take care of all those genotypes. It would be really well tolerated. There would be no resistance. Now, it's really weird that you could have millions and millions of viruses replicating every few seconds, and then you bring one agent in and push it through the body, and you kill out all the viruses. Now, that's really, biology is not like that. The virus will do whatever it can to survive, but somehow we were effective, or they were effective with sofosbuvir. You would give the medicine once daily, and you'd only give it to 4 to 8 weeks. And how simple that is, and this is where we are now, okay? So I talk a lot to primary care, to nurse practitioners and physician's assistants. This is not rocket science, but we need people to feel comfortable with all the things that I just talked about, and they're not. The internists and family physicians are not comfortable with identifying liver disease. They're not comfortable with talking to their patients about it. So we have this huge disconnect. Now, just like HIV, we move forward slowly with all sorts of different agents trying to find the right combination. And mostly what we're going to talk about now is only 3 agents: Epclusa, Mavorette, and Vosevi. Unfortunately, this is spelled wrong. Epclusa, Mavorette, and Vosevi, okay? Now, we have all these other choices, and, and in certain combinations, they're very successful. But we really want to simplify this at, with a 95% cure rate, and we, again, are there now. So, talk about sofosbuvir. This is the wonder drug. Sofosbuvir changed everything. Gilead, which is a very smart company, very clever, they said, we're going to spend $12 billion acquiring the whole pharmaceutical company that has sofosbuvir, and Wall Street went nuts. And, of course, then they made $12 billion in the first year after acquiring it. So they're very, very clever. The highest sales ever for a new drug was $10 billion in 2014. There is another drug that makes $10 billion a year. What is it? Humira. Okay, so just so you know, GI's into everything, right? So the first list price was $84,000. Okay, about $1,000 a tablet. I could say all sorts of quips now, but no one pays cash for this drug. No one. Okay, and again, this is only in the United States. So in Pakistan it costs $39.99. Okay, so $39.99, right? So it's this is just the way things go, and the cost now is around $23,500 for a course. And it will continue to fall, okay? Insurers went nuts, but there were tons of prescriptions because people like me had all these patients warehoused. Competition effect is happening, but Medicaid is rationing therapy in Iowa, South Dakota, Nebraska, and around 10 other states. Now, only 10, so it's really coming in, the pressure on the red states to stop doing this. We have a few minutes, I think. So, so Obama sent a letter to all the states saying, cease this. It's illegal. Rationing in the United States is illegal. And, of course, they ignored him. So, but I think that we're going to see these other states stop rationing therapy. Okay. But incredibly expensive. So California said, well, we could remove dentistry from Medicare or treat people with HCV therapy. So, brush your teeth. So, okay. So, it's very simple. You have Epclusa or Mavorette. Harvoni is only for genotype 1. So Harvoni has these amazing commercials that were so effective, but it's only for one genotype, right? Okay, so, 1. But Epclusa and Mavorette are pan-genotypic, and I think that they'll be the choices people will gravitate to. And it's basically Epclusa or Mavorite 8 weeks or 12 weeks. So it's going to become simpler and simpler. Is there cirrhosis or not? Now, knowing that the hardest thing is to get the medication for your patients. And this is when a lot of people say, even if I do all these things, Dr. Mailliard, you just talked about, the burden of acquiring the medication through pre-authorization is significant. And so you have to partner with your specialty pharmacy. And we've been very pleased with Sanford's specialty pharmacy in assisting us in getting medication to these patients. I don't, do you think so? And, you know, the 340B program, you know, I don't know if you know what that is. So hospitals associated with a lot of needy patients were given discounts, hopefully to provide support for all sorts of programs for needy, financially needy patients. But what happened was, of course, you know, for every time this happened, people gamed the system. You know, so like the University of Michigan, Ann Arbor made it makes over $300 million a year just from the 340B. That's pure profit. What could you do with $300 million? A lot. But frankly, the specialty pharmacies are critical because they get very comfortable negotiating in a rapid way and applying for this therapy. So we think that about 85% of our patients get therapy within a month. They don't get therapy when we write the prescription. So we're always working behind the scenes. We have about a team of about 6 people working on this. And of course, because we still make so much money, it makes sense. Now, Medicaid, I mentioned a little bit, so fibrosis algorithms remain. So how can you ration for therapy? Well, you would simply say you have to have a certain degree of scarring to qualify for therapy. They would, although this has not ever been shown in a prospective fashion, you have to have stage 3 or 4 fibrosis, pre-cirrhosis or cirrhosis to get therapy. Puts a tremendous burden on me to try to identify those patients to prove. We don't do liver biopsies for this at all anymore. Liver biopsies cost $4,000. It's like having a root canal. We're not doing it, okay? So we do elastography, you know, and your GI folks here, of course, do elastography all the time. And ultrasound has elastography, and MRI has elastography, and it's very good at identifying fibrosis. But hopefully, as I already said, that algorithm will collapse. Sobriety. Sobriety is required for many states to obtain. You have to prove sobriety. Well, you know, I don't know. As I started out with my first rant, was about everybody drinks alcohol, you know, and so, you know, asking these people to be sober, well, good luck with that. We spent a lot of time on that. We are finishing one investigator initiation showing that Harvoni is wonderfully effective on my heavy drinkers. So in order to get into our study, you had to have a score of 8 or more, which means you're a very unhealthy heavy drinker, like, you know, the gastroenterologist. And, you know, so they were given Harvoni, and we have 100% cure rates. You don't have to be a gastroenterologist anywhere to do this. The states also sometimes required you have to be a gastroenterologist to prescribe this medication. That's been totally debunked. So here we are, and hoping that Medicaid, as the cost falls in the low 20s, which is very, you know, you can spend $20,000 on your patients really, really easy. So we think that Medicaid will give it up and allow all patients to be treated who have Medicaid. And about 40% of adults who have Hep C have Medicaid. So we have a Cure Hep C Nebraska program. And the goal would be to eliminate all viremia in Nebraska. So in theory, you know, just like, other infectious diseases, can we globally eliminate hepatitis C? Because about 10 years ago, this astronaut scientist said that hepatitis C will follow us when we ditch this planet, okay? Go off to whatever. So, but that may not happen. So, and the potential is to eradicate it, eliminate it, and in order to do this, we need all sorts of people partnering to get this done. And so I think we're well on our way to do it. And Nebraska is just one state. There are whole countries. Australia is going to get rid of hepatitis C in Australia. Amazing. So there are areas in the world that have chosen to get rid of this, partnered with Gilead, partnered with AbbVie, and are going to make this happen. We need, of course, Medicare, Medicaid, the Indian Health Service, all these people to get together and pay attention to this program, public-private partnership, and I think it's well on its way. I don't think we're going to make 2025, though. So, in summary, is it too expensive to treat or too expensive not to, right? It should be obvious. Screen, confirm, and treat. Partner with your specialty pharmacy. They're still making some money off this. They want to help you. Educate the patients and the providers that this is so doable. Remember to identify cirrhosis because they're the ones who might get liver cancer, and the natural history of liver cancer is changed by early diagnosis. So make sure you check to see they're cured. We have trouble making sure those needy patients come back to be shown. They take their medicine, but we need to show that they're cured. And then finally, there is no bigger problem in the United States other than opioid abuse. Clearly, it's the everything, alcohol and opioids, okay? And, we need to be very open and honest in talking about this and acknowledging where it sits in our lives and the risk to us from that. So that's my speech, my rant, and I think we have a few minutes for questions. Thank you. Yes, sir.
Thanks. Very authoritative. We really are grateful for your leadership. I have a two-part question. Does Nebraska do better than 15% in terms of primary care docs screening for HCV in the adult?
I don't know. That's national data. I don't know. I doubt it. I don't. Does Nebraska do better? Nebraska is a very, like you guys, a homogeneous, affluent population. Nebraska has a couple counties that are the poorest in the United States, so the poorest 10. So there's an area in Nebraska where it's really difficult to farm. But, again, a very homogeneous population that's highly educated, just like South Dakota, okay? High quality of life. You would think that we would be doing better at this than we are.
I thought you might know, because I was going to say, what's the number for South Dakota? I figured you had our state nailed too. Well, since we have Epic at Stanford, Meditech at Avera, and other systems have capability, we ought to be able to get an answer.
Yeah, so Epic, everybody has Epic or the other one, and it should be very, very powerful tool. So, in Omaha for the last 2 years, it's been part of that warning. This patient needs a hepatitis C test.
Yeah.
So,
as a primary care doc, it just really surprises me that number is so low. I don't screen everybody, but I go there when the health maintenance prompt fires. What can we do better as primary care docs and other specialists?
Well, I think
to screen.
If you're going to screen, you have to have a little bit of a 3-sentence spiel. Like, this is very common. Most people feel fine. Let's get rid of this. Just like treating your blood pressure and your obesity, diabetes. And by the way, you still drink too much. Those things. You know what I mean?
So get it into the workflow and practice.
Okay. Yes. Other question? Yes.
Could you speak to your practices for follow-up of hepatocellular carcinoma screening after successful treatment?
Yeah. So, are we as GI/hepatologists going to do and order the ultrasounds every 6 months for the rest of their lives? That, I think, is asking a lot. So I tell the primary care providers, I'm writing in my note, I'm passing this to you, and the medical legal consequences. The biggest malpractice that I face is hepatocellular carcinoma in cured patients with cirrhosis, okay? So I look at patients in the eye and I try then to say, you've got to make sure that until we come up with a better way to screen, you got to have an ultrasound. Alpha beta protein is not involved in that. Okay, so it's just ultrasound.
So this is just in your F3, F4
Yes,
fibrosis patients. You're
Yes.
still recommending every 6
Yes.
months ultrasound.
that's all we got. And I think that'll go away. There'll be better testing, but there isn't any yet. You're welcome. Other questions, comments? Yes, sir.
Looking into possible transplant, we treat them before or after the transplant.
Well, that's very controversial. That's an excellent question, and I could give about a 30-minute talk about this, okay? Now, some of your patients that you're curing of hepatitis C, you're going to change their portal hypertension. It's not as much as I was thinking it was going to be, okay? So, if you suppress hepatitis B in someone with 25 million hep B virions, they have a remarkable clinical sequelae within weeks. But if you cure hep C, it's not like that. So right away, the patients who have decompensated liver disease don't get all better. But you can make them better enough that you can decrease the chances of them getting a liver transplant, and then they can die free of their hep C. This is the sort of problem. So should you wait until afterwards and treat them afterwards? So, I don't do critical care hepatology. So I have 4 partners who do that. And I know sometimes they delay therapy because they're afraid that they'll prevent liver transplant by curing the patient. But these has to be individualized. But the biggest news is these organs that are hepatitis C infected, are you going to use them? It used to be that we thought this would be malpractice, and this caused because you couldn't guarantee cure. But now we can almost guarantee cure post-transplant. So all these hepatitis C organs coming from baby boomers or from unfortunate victims of the opioid epidemic, can we use their kidneys? So the nephrologists are very, very keen to use their kidneys, okay? Some livers, kidneys, hearts, and lungs, right? I think, though, I'm conservative and, a bit of a geezer here. I've seen immunotherapies associated with exacerbation of rapid disease and decompensation. And so the younger people getting the informed consent don't know this. So it's really hard for a surgeon and his team to get informed consent for that. Plus, you have to absolutely guarantee the patient will get treated after the transplant, and it's not there. We had a patient who was dying of lung disease who got a new lung, who had hepatitis C. Lung had hepatitis C, and then he acquired hepatitis C infection. It took them about 4 months to get approval for the hep C therapy. I just said I'm looking to testify in that case, So it's very tough, and I don't mean to be a jerk about it, but you have to cross your T's and dot the I's, because, to transplant surgeon, they're completely goal-driven toward a small area. Okay, wonderful people that they are. Yes,
When you screen for hepatitis C in those patients, are you also asking if they're positive to get HIV and hep A/B and all those other
Yes.
things at the same time? Or
Yes.
are you
So
encouraging from a primary care
we
standpoint?
embark on hepatitis B screening and HIV screening on 100% of our patients, okay? And we used to not be that way. And I'm surprised of the HIV I found. I didn't know that you could be walking around with HIV for a long time, is what I know. But yes, because the therapy of hepatitis C may change the immune system's relationship to hepatitis B and HIV. And therefore, then you can have an exacerbation of disease. And there are anecdotal, but more than just 50, cases where the patients got into trouble from their hepatitis B once you cured their hepatitis C. And there were deaths. So you have to, there's a way to identify this and follow them. Other questions, comments? Thanks a lot. Appreciate it.
Move it or lose it, sister.
Guess I'm leaving that
Just go back to work. Stay like us.
So that's our issue. You'll come here if I never hear about the Mayo clinics.
All right.
I did hear.
I don't have a strike